Welcome, everyone, and thank you for those joining us live today and to those listening in afterwards. I would also like to warmly welcome our guest today, who I will shortly introduce in a while. So just taking care of some technicalities, you can see on the next slide our guests and the alignment for today. Here they are. I'm pleased to announce to you all that we have more than 730 registrants for this event. Of course, that we know by experience that sometimes participants take some time to join in. We also have people from different time zones, and usually pharmacists are very busy professionals. So we are aware as well that some people just might join us a little bit later. I'm also happy to share with you that we have simultaneous translations both in German, Italian, and Romanian. In order to change the language, you can click on the interpretation option on the bottom left part of your board. And so it's time to introduce myself. As you can see on the next slide, my name is Lourenço, and I'm a community pharmacist from Portugal. I'm currently the professional secretary of the community pharmacy section and also a member of the board of pharmaceutical practice of FIP, the International Pharmaceutical Federation. I'm also serving as a member of the Portuguese Pharmaceutical Society, both at regional and national level. And for me, it's an honor and a privilege to be here moderating this event and to welcome not only the registrants that actually took the time just to join us, but also our guests who took also the time and the energy and enthusiasm to prepare their presentations. So as you can see on the next slide, FIP vision is a world where everyone benefits from access to safe, effective, quality, and affordable medicines and health technologies. Our mission, you can see on the next one, is to support global health by enabling the advancement of pharmaceutical practice, sciences, and educations. And I will take this opportunity just to promote the benefits of our membership as well. We have an FIP member organizations who can actually register as a member of FIP, but also individual member. So if you are a pharmacist or a pharmaceutical scientist and you have a particular interest, please just check the website. Please just approach us so you can become a member of our federation. And as you can see on this slide, we have some announcements to make. The webinar is being recorded right now in live stream on YouTube. The recording will be available on our website. You need to be a member to access the event. Afterwards, you may ask questions during using the question box provided. I'll do my best just to manage all the questions so that at the end, at the Q&A part on the discussion panel, we'll be able to address those questions to our panelists. Again, you are welcome to provide some feedback. We're always keen to hear what topics you like to be approached, what other subjects would like to be discussed in FIP events or digital events. And as I mentioned previously, do become a member of FIP if you feel like you want to be part of this big international pharmacy family. So in our next slide, you can see, as I mentioned, or the info about if you want to put any questions, just write them down on Q&A tool. I'll be one moderating it. And I would like to thank you, Racket, as mentioned on the next slide, for the support of this online program, which has been a fruitful partnership between FIP and Racket. Then on the next slide, you can see the learning events, learning objectives for today's event. This has been already shared previously to all registrants and promoted as well on our social media. And on the next slide, you can see the program of the webinar. Actually, we are pleased to be leading this event, which is the episode number 4 of our program of 17 events on self-care, shaping the future of self-care through pharmacy. As healthcare providers, pharmacists have an important role to play in supporting self-care. This program is composed of 8 episodes that we focus on accelerating universal health coverage for all by enabling self-care through community pharmacy. And additionally, 9 episodes will focus on self-care support for community pharmacy teams. May I remind you that on June 24th, the WHO started the Self-Care Month, which will lead to the Self-Care Day on July 24th. Some tips to improve your health will be shared, new guidelines will be launched, and the events will be organized showing how health systems can promote self-care, intervention, and advance health and well-being for all. Please note again that this event is being recorded and live streamed. You have if you are an individual member, you can actually access it later on fip.org. And I'm very pleased now to be introducing our first panelist. You can see right now on this panel, Dr. Laura Murphy, which is a pharmacy clinical leader and clinical investigator at University Health Network, and associate professor at the Leslie Dan Faculty of Pharmacy, and co-chair of the interprofessional pain curricula with the University of Toronto Centre for the Study of Pain. She's a member of the expert advisory panel for the Canadian Pain Task Force and the National Faculty on the use of opioids for chronic non-cancer pain. Dr. Murphy's clinical practice is within an interprofessional chronic pain team at Toronto Rehab, and her research areas of interest include opioids, cannabis, and roles of pharmacists to support people living with pain. I think we'll be very pleased to hear Dr. Laura. Laura, the virtual floor is yours. Thank you so much.
Thank you kindly for this invitation to speak today. And thank you so much for that lovely introduction. So I'm going to jump right into my slides because I know we have a busy panel. So next slide, please. So I have no disclosures related to this presentation. I wanted to share that I've not received an honorarium for creating this presentation, and the slides presented today are my own. Next slide, please. And so I will be focusing on describing how, as pharmacists, we can support people with musculoskeletal pain, and also to describe appropriate management in the choice of medicines for musculoskeletal pain. And on the next slide, I'm going to jump right in. So I believe strongly that pharmacists can play a very important role supporting people living with pain, and in particular musculoskeletal pain, given how prevalent it is in our society. We know that almost half of the population will have experienced some musculoskeletal or MSK pain in their lifetime. And we know that many people, approximately 1 in 5, transition to experience persistent or chronic pain. We know that this is disproportionately higher in women, children, people who use substances or other drugs, veterans, as well as people with mental health illnesses. And so there's a lot of stigma associated with both persistent pain, but also many of these characteristics. And in particular, our Indigenous population are also disproportionately impacted by chronic pain. And so in particular, as pharmacists, we need to be sensitive to this stigma and try and support people to overcome it. We also know that adverse childhood experiences and trauma can worsen the experience of pain. And so as pharmacists, we need to be sensitive to that as well and be trauma informed when we're providing care to people. I've included a quote here from a famous singer, stage name Lady Gaga. And I think that this quote really speaks to the fact that people who experience pain not only are suffering from their pain, but they're suffering from the stigma and how people treat them. And that is the first way that we can support people living with pain, is helping them to overcome this stigma. Next slide, please. So this slide is speaking to the musculoskeletal pain and the pathway to chronicity. MSK pain can present as localized, regional, or widespread, and the intensity of ongoing pain and duration of pain can determine the degree of muscle hyperalgesia. This underpins the importance of ongoing nociception for the chronification process. You can see here I've listed different types of pain. There can be primary pain conditions associated with MSK pain, including low back pain, cervical pain, thoracic pain, myofascial pain, which can be particularly sensitive to the chronification process and hyperalgesia process. But there also can be MSK pain secondary to infection, autoimmune disorders, osteoarthritis, injury, and cancer. Next slide, please. So here we can see the different characteristics of pain, or the underpinning pathophysiology of types of pain. And MSK pain can actually be composed of all three of these types of pain. So where we see the overlaps in the circles. So we do have nociceptive pain, which can be defined as actual or threatened damage to non-neural tissue or activation of nociceptors. And these are the definitions from the International Association for the Study of Pain. We have neuropathic pain, which is defined as lesion or disease of the somatosensory nervous system. But both of these exclude pain without activation of neither nociceptors or lesion or disease of the nervous system, like in the rheumatology setting, for example, with non-specific back pain or peripheral joint pain or fibromyalgia. And so, in the last 5 years or 10 years, we've seen the introduction of this third mechanism of pain, nociplastic pain, which is altered nociception and no clear evidence of actual or threatened tissue damage. Next slide, please. So here I've identified different features of nociceptive, neuropathic, and nociplastic pain so that to support us as pharmacists to be aware of what can be involved with the different types of pain. As we move from nociceptive pain, which is usually intermittent and sharp with movement or mechanical provocation, and people may describe to us a constant dull ache or throb at rest, there should be no night pain associated with this mechanism, to neuropathic type pain, where pain is referred in specific dermatomal distributions. And people may describe it as having dysesthesias. They may say they have crawling skin, electrical shocks, heaviness. They may also have positive neurological findings. So that's where they have decreased sensation, maybe where they have pain, or changes in muscle power associated with the muscles around. And then nociplastic pain, we can see there are more what we describe as systemic or constitutional symptoms. Pain is spreading all over, or you see widespread pain. People are experiencing fatigue, sleep disturbances, numbness, low libido even, and a swelling sensation in the area. And so when we start to hear about these types of symptoms, we know that we should approach the management of this type of pain differently. Next slide, please. Self-management is the ability to adapt strategies to better manage the physical and psychological challenges of pain experience, or to essentially cope with their pain experience. This incorporates physical, psychological, and pharmacological strategies to cope with pain. As pharmacists, we can help people put these puzzle pieces together to approach pain management with a multimodal approach. Pharmacists' role supporting self-management is essential, and it can really include things like pain education. Studies have shown that teaching patients about neurophysiology and neurobiology of pain reduces pain, catastrophizing, healthcare utilization, and improves function. Other psychological approaches that patients can be trained with include cognitive behavioral therapy, mindfulness-based stress reduction, and also ACT, acceptance and commitment therapy. And pharmacists can also guide them to use physical approaches like exercise, rest, stretching, heat, to self-manage their pain. This is also a good opportunity for pharmacists to work with interprofessional teams to create a plan. Finally, physical and pharmacological strategies can reduce the, physical and psychological strategies can reduce over-reliance on pharmacological treatment. And pharmacists can play a role in this as well. Next slide, please. So here I've just taken the pharmaceutical care approach and tried to tailor it a little towards pain medication and reducing reliance on pharmacological strategies. Now, certainly not everyone has access to a broader interprofessional team in their practice, and not everyone has access to all of the modalities that I've described previously. But as pharmacists, certainly we can support people as medication experts to make decisions around what medications they should select, medications in their history, so that we can look for things like interactions and synergies. We can look at what medications are not needed, and support people in safely tapering and stopping them. So there are many roles for us here. Next slide, please. I'll focus on medication selection. So there are many factors that a pharmacist should consider when choosing a medication. This is not different from other clinical conditions, but certainly when it comes to pain and the management of chronic pain, patient choice starts to play a very important role, because we need for them to buy into the treatment plan for it to be effective. And this applies to both starting a medication as well as tapering or stopping a medication. Other things that should be considered are patient-specific factors, both physical factors, history, so their response to prior drugs, as well as, if available, pharmacogenomic data, which can guide us. And international guidelines like the CPIC guidelines have selected certain pain medications where pharmacogenomic data can support us in selecting an agent that may decrease different medication trials. I just wanted to highlight that as a key factor that we can look at as pharmacists and support our colleagues in interpretation of data. Next slide, please. Now here lists the medication alternatives for the management of MSK pain, and we can see that it's a very long list, starting with acetaminophen, or I know elsewhere in the world it's described as paracetamol. We, of course, have non-steroidal anti-inflammatory drugs. Both of these are excellent options, in particular for acute MSK pain. We also have opioids. And I should note that this slide does not order the options in terms of choice of place in therapy, like first-line, second-line agents. I've just listed all of the options that are available to us. Different options may be selected for different features of pain, whether the pain is localized, for example, and we may select something like an injection or a topical agent that can be used, or if it's more widespread and nociplastic in nature or neuropathic in nature, we may choose some of the options at the bottom, things like anticonvulsants, antidepressants, or even cannabinoids to support people in management of their pain. Just a word on opioids, I'm going to elaborate further. Opioids have been shown to have medium effect sizes versus placebo to reduce pain short term, but there are, of course, risks of adverse effects. And here in Canada, we have an ongoing opioid epidemic, just like many other places in the world, but in particular in North America. And so we are quite sensitive to a balanced approach in the management of pain using opioids. So next slide, please. I think we're actually going to move to a poll at this point. I had a placeholder. Could we bring up the poll for the audience to participate? So I'm just interested in the approaches from all of the participants on the line in terms of place in therapy of opioids for musculoskeletal pain. Would you link it as first line, second line, or having no place in therapy? Okay, so I can see that some people have chosen first line. The majority of the audience have chosen second line, 79%, and 10% of participants have identified as it having no place in therapy. And so this is a difficult question, given that MSK pain, like I've just already described, encompasses very broad-ranging conditions. It can have different underlying mechanisms. And so, of course, some people may have wanted to choose the option, it depends, which I didn't include there. But for the most part, I would agree that it is neither a first-line option for either acute MSK pain or chronic MSK pain, yet there is a place in therapy for it. So it is generally second line or lower in some conditions. So interesting to see that widespread in terms of options from the audience. Thank you. So as I mentioned, here in Canada, we are very focused on common issues related to pharmacological management of MSK pain. And one of these in particular that we know of, and it does extend beyond Canada, is the overuse of opioids. And so data from these studies that I've listed here have identified that not only are opioids used more frequently than would be guided by different guidelines, we also see that opioids do not generally achieve greater benefit than that of NSAIDs, for example, in this first study of the systematic review and network meta-analysis over NSAIDs and acetaminophen, there wasn't significant benefits. We also see from the NIH in the US that patients with newly diagnosed MSK pain are prescribed opioids more often than recommended by the guidelines. And this study, the COPERS trial down below from the UK, which looked at a cohort analysis of primary care, found that there was also overprescribing for chronic musculoskeletal pain. And this is very typical in terms of what I see in practice as well. Next slide, please. So as I mentioned, in Canada, we have an ongoing opioid epidemic. When we look in 2018, we can see that 1 in 8 people were prescribed opioids. This is reduced from previous years where we saw probably a peak in opioid prescribing around 2010 to 2012 when I was earlier in my practice. And I've really seen this as a journey, a pendulum swinging back and forth where, when I was trained, we learned that opioids had no ceiling effect, that patients could not become addicted or develop opioid use disorder if they were using opioids for pain. And we know that that was heavily influenced by pharma marketing, some of those messaging and the misuse of data. But in more recent years, in terms of management of the opioid epidemic, I've actually seen a swing in the opposite direction where not only are we reducing our use of opioids, but there have been unintended consequences of some of the policies and actions to overcome the opioid epidemic, and people who are experiencing pain actually have less access to opioids than they ever did before. And this has left many people who did have opioid use disorder to turn to other non-prescribed opioids. So we are seeing a great increase in terms of the number of people who are using fentanylogs and street opioids. But in terms of management for pain, we are seeing just a deepening of the stigma and often sad cases where people have been abruptly tapered or experienced other adverse effects as a result of these actions. So we need to be sensitive to that as pharmacists, and as I mentioned, take a balanced approach. And I just included here the world ranking, because although in Canada you can see along the top up until 2019, actually our world ranking in terms of consumption of opioids has decreased. We peaked at being second in the world after the US in 2013, coming down, and then more recently we are 4th in the world. But we are seeing elsewhere internationally opioids actually emerge as becoming a larger problem and consumption vastly increasing. Now, I am not an expert in global use of opioids, and so I can't necessarily comment, but we know that this could be from different reasons, either increasing access, appropriate access, or potentially people are moving towards the same pendulum swing that we saw in Canada. So this is just hopeful that we can become a cautionary tale for other countries to learn from. Next slide, please. Now, one of the actions that occurred to overcome this epidemic was the release of first a 2010 and then a 2017 clinical Canadian opioid guideline for the management of chronic non-cancer pain. And these recommendations were very carefully worded, drawn from literature, so evidence informed. And when we see there are key opportunities for management of opioids, one is not to give an opioid to some people in particular if people have active substance use disorder, to try and avoid it or use other options. Also to optimize all other options before opioids. Another is to try and keep the dose at or below 90 milligrams of morphine equivalent per day. And if people are at that dose, because we know that there are dose-dependent adverse effects associated with use of opioids therapeutically, for people to trial a taper. And that is where much of my clinical practice has been focused on for the last 10 years. Next slide, please. Now, these are the opioid-related harms that I was speaking to, where we're seeing increasing use of fentanyl and also increasing mortality as a result of this use. So early in 2016, you can see on the left, the infographic describes that nearly 60% of the opioid-related deaths that we saw in Canada had only prescribed opioids present. And then on the right, we can see that more recently, from January to September of 2020, when we are deep within the COVID-19 pandemic, which has vastly influenced our opioid epidemic here in Canada, we could see that now over 82% of opioid-related deaths involve fentanyl. And so this is a very disturbing trend. But one, of course, that is related to the use of opioids for chronic pain, and so we monitor it very closely. Next slide, please. Again, this is just looking at the trends by region, and we can see that over time, in Canada, we have seen some reduction, but this is by region more generally. So in North America, there have been some efforts to reduce, and we see some fluctuations in the last few years, but we can see in other regions this use increasing, and that's what I was speaking to just a moment ago. Next slide. So beyond the risks associated with our opioid epidemic, which include overdose and deaths to individuals, there's also, of course, opioid use disorder, and we see somewhere around a 6 to 10% rate described, around an 8% rate for those using therapeutically. But there are also a whole host of other opioid risks that as pharmacists we can inform our patients about when they start using opioids for pain, and these become worse over time and with increasing doses. And I will draw your eye to the bottom here as well, that opioid-induced hyperalgesia, this paradoxical effect where opioids can make pain much worse, I see very frequently in people who have MSK pain. We know that people with myofascial pain in particular are very sensitized to hyperalgesic states, like I mentioned in the beginning. And so we need to be careful when we're starting opioids in those types of underlying pain conditions, because we may be putting people at increased risk. Opioid withdrawal or interdose withdrawal, which can happen, especially if we're using extended release products, should also be monitored quite closely. And as pharmacists, we can help reduce this impact. Next slide, please. So our last role is really supporting people to stop medications. And as I mentioned, a large clinical focus for me is doing this. Of course, if people have ineffective results from pain management or intolerable side effects or risks associated with their therapy, then we can set goals with them to reduce their substances, support them in likely a slow and safe taper to support them to avoid suffering from withdrawal, and then hopefully celebrate success and revisit their goals associated with pain management. And I can't underline this enough, that our journey with the patient, if we're supporting them in stopping a medication, is not to say that is the end, because often they are going to be dealing with their pain condition long-term. And so they're always going to be looking for what other coping mechanisms can they rely on. And this is an excellent opportunity to revisit the discussion around self-management of their pain. Next slide. This is just illustrating that I collaborated with a group of pharmacists across Canada to support the development of a guidance on opioid tapering in the context of chronic pain. This is evidence-informed, but not evidence-based, consensus-based. And if you are interested in more resources, you can certainly refer to this publication. Next slide. I would be remiss if I didn't also identify other common issues in the pharmacological management of MSK pain, but I'm approaching my time. And so I just wanted to highlight that there are, of course, issues related to duplicate therapy that we see all the time, as well as complex interactions that we need to be aware of, things that increase accidental opioid overdose related with gabapentinoids and benzodiazepines. There are many drugs used for pain that have the potential to cause serotonin syndrome, and that's the table that I have in the middle here. So we should be aware of these interactions and manage them well. And then there's also many medications that risk QT prolongation. And so there may be appropriate monitoring needed depending on the group of medications and underlying comorbidities for our patients. Next slide. And finally, related to the use of cannabis, certainly cannabis has been recently legalized in Canada, but there are many, many people using it without a medical authorization. We have two systems. We have both a medical authorized system as well as a legal system for access of cannabis. And many of our patients are bypassing now the medical authorization to self-manage their pain with use of cannabis. I've included a little bit of information here. Essentially, it's not for the management of acute pain, and there's only limited benefit for management of chronic neuropathic pain conditions, but really that benefit may be outweighed by the risk according to a recent Cochrane database system review. And so I've included here some suggestions that there is still a role of the pharmacist, role for us as pharmacists, working with people who are self-managing their pain with cannabis to help reduce harm associated with that use. But it's beyond the scope of my presentation today. Next slide. And so I hope I've achieved these objectives, and I will turn it back over to the moderator. Thank you very much.
Thank you so much, Laura. A very intense, I will say, and although interesting presentation. We have a lot of people from the four corners of the world just saying they are actually present. This event, due to the time zone, sometimes we were supposed that we thought that maybe people out of Europe wouldn't participate. We have people from India, we have people from South America, Central America. So just a big cheers for all of them. They've been sending their regards to the organizers and also to the panelists. And we have some Q&A as well. And I'd like to emphasize that if during the presentation participants just think that they would like to have a deeper insight on a specific topic, just write them down on the Q&A area at the bottom part of your screen. And now it's time to move forward with the second presentation, which will be around Professor Philip Cunningham, who is the Director of Leeds Institute of Rheumatic and Musculoskeletal Medicine, a ULR Center of Excellence at the University of Leeds, and Deputy Director of the Leeds Biomedical Research Center. His research focuses on understanding pathogens and developing effective therapies for common arthritis and joint problems. He's an executive member of the International Outcomes Group, OMRAC, and he has previously chaired the UK&I's Osteoarthritis Clinical Guidance. He's the co-editor of the Oxford Textbook of Rheumatology and has authored or co-authored over 600 publications as original research, reviews, and book chapters. Phil, the floor is yours. Thank you.
Thank you very much, Lewis. For those of you getting up very early in the morning to listen to this live, that introduction alone has probably put you to sleep. So well done for being here. Hello to everybody around the world. And I know some countries represented on the call today, on the meeting today, are having much worse COVID problems than we are at present. So good luck with your everyday battles. I'm going to talk about, next slide, please. I'm a rheumatologist. I still see patients and do clinics, but I have very much a research focus in what I do. And of course, being an old man now, I also have musculoskeletal problems and a bit of osteoarthritis. So I'm not so different in some ways from many of the patients I'm seeing. But I'm very cautious as a rheumatologist talking to pharmacists that when I was a young doctor, everyone told me what to do because I needed it. Now I'm an old doctor, I'm too scared to tell anybody what to do because I've realized most people's jobs are quite different and that I only have an idea what people do. I don't do their job. So you have to take what I say as it is from a secondary care, tertiary care hospital clinician talking to you with his ideas, because I've spent 30 years worrying about how we treat common problems of joints and wondering why we don't get more people involved like pharmacists. Next slide, please. I like this map just to show that Leeds is in the centre of the country there, because whenever I give this talk, nobody knows where Leeds is, especially the people in London. And for those of you who pick up on accents, next slide, you'll tell that my accent actually is probably from here, not from Leeds originally. So you're not crazy if you think my accent doesn't sound Leeds-like. Next slide. So I want to cover today, this talk is probably a bit more practical than theoretical. And I'm going to talk about what is arthritis, why are joints painful, and what can pharmacists do for people with joint pain. And a lot of my discussion today is really based around peripheral joints more than back pain. And yet some of the rules, same rules do apply. Next slide. Now, when I say to my medical students how many types of arthritis, joint and bone conditions are there, they normally guess 3 or 4. When I tell them there's over 200, they're always a bit shocked. And average community understanding of arthritis is it's something my grandmother got as she got older. That's what most people think. It's a disease of old age. Now, I think it's worth thinking about, there are different types of arthritis, but we need a simple classification. Next slide. Now, if you look at this list of problems, most of these things will be familiar to you. And next slide. The ones in red there are the ones that are the most common ones. And it's back pain, osteoarthritis, and gout being the most common inflammatory arthritis, and also on the increase. If you look at most people will get back pain at some point in their life. About 10% of adults will get osteoarthritis. Crystal arthritis is now about 2.5% in, at least in Caucasian populations, and there are genetic differences. Osteoporosis is very common and increasing with older age living females. Rheumatoid arthritis, about 1% of the population. Ankylosing spondylitis, 0.1%. And yet, because those latter diseases have much more impact often and are much more drug intensive in their treatment, that's often been the focus of certainly secondary care. Whereas the first 3 in red there is what primary care and what you will see in your everyday management and dealing with clients, that's what you'll see a lot. Next slide. Now, how do I classify these 200 different types of arthritis? Well, I think of things as being primary mechanical in origin, and osteoarthritis is a good example of that. And when I say mechanical, it means joint symptoms that are worse with youth. And primary inflammatory origins are diseases of the immune system, and they tend to be worse often with tissue. So morning stiffness is the key feature of these. And we've got to distinguish those, and I'll come back to that in a minute. Now, of course, you can have more than one type of arthritis. People who've had osteoarthritis for years can get rheumatoid arthritis later in life. And similarly, people who've had rheumatoid arthritis, a disease of the synovium or joint lining layer that eats away at your joints and destroys the joints, they get secondary osteoarthritis. And it's very important to realize most people get more than one type of joint pain. Most people have more than one joint involved. The commonest number of joints in people over the age of 55 is 4 joints. Next slide. So this is really important, and this is how to make you rheumatologists in just a couple of minutes. It actually doesn't take that long to become a rheumatologist, so you might as well learn the tricks because you will be talking to patients as much as I am, and probably a lot more. The key question that helps me decide if people have inflammatory or mechanical joint problems is that of early morning joint stiffness. And if it's more than 60 minutes duration, then I start to worry that somebody has an inflammatory arthritis. Up to 60 minutes, there's much less chance. 30 minutes is mostly other things. So it's worth asking somebody how stiff they are first thing in the morning when they get out of bed. Normally people say, oh, my knees are sore for 10 minutes, then they free up and I'm walking a bit easier. That's very typical of osteoarthritis. Now, age is sometimes helpful. There's no question as you get older, you get more tendinitis and osteoarthritis problems, but it's never a total excluder. If you get all your knuckles of your hands and feet involved, then I start to worry you've got rheumatoid arthritis, if you've got widespread disease. Associated diseases are helpful. Sometimes people have got the disease psoriasis, and about 7% of people with psoriasis can get an inflammatory arthritis. But the majority of people with psoriasis with joint pain, it's mechanical osteoarthritis, tendinitis, joint pain. Some recent infections, diarrheal illnesses, people who've picked up various diarrheal illnesses can get what's called a reactive arthritis, often involving one knee or a knee and an ankle. And some sexually transmitted infections can also be related to a reactive arthritis. Sometimes people have features that suggest they've got a broader connective tissue disease. So they might have a rash that comes out when they go out in the sun, or have severe Raynaud's with colour changes affecting their fingers. So those people I screen for connective tissue diseases. I'm not expecting you to start examining your clients, but joint swelling, true joint swelling is really important. Patient-reported joint swelling is a very poor sign of inflammation in the joint. But psoriasis is something that patients sometimes don't know they have, especially if it's in hidden spots on the body. And we do a number of blood tests and other imaging tests sometimes to sort people out. But 80 to 90% of my diagnoses are still made on history alone. And I'm going to come back to early morning stiffness is really important. If you wake up and are lying in the bed with no symptoms, you then stand up and notice that your knees are aching, your toes are aching, something else is aching when you walk, that's a mechanical joint problem. Similarly, you might be sitting in a lecture, as we used to do 100 years ago, sit in lectures. And you get up after that for after half an hour, and you're a bit stiff moving. That often means you've got some tendinitis or maybe a bit of early osteoarthritis. But typical rheumatoid arthritis, you've got 1 to 2 hours of morning stiffness that frees up as you get into the afternoon. And for ankylosing spondylitis, the inflammatory arthritis involving the spine, our average time to diagnosis is still 9 years. It's appalling. And that's across a lot of different countries, we see the same figures. And that's because back pain is so common, we don't distinguish it, but morning stiffness is the one key thing we can ask people about. So pain that's worse, pain stiffness that's worse for a long time in the morning is something always to be considered. Next slide, please. So where does the pain come from? Well, Laura talked about types of pain. I'm talking really about what she would term peripheral nociceptive pain. And my worry is that many of the pains we've interpreted as central and others is because the x-ray was normal. And x-rays are a rather rubbish test for anything except fractures. They're not a great test of anything much. They don't see soft tissues. They don't see the synovium, the joint lining tissue, which, by the way, patients have no idea about. They don't see inflammation in tendons. They don't see where the tendons attach to bone, what we call the emphasis. And they don't see problems within the bone. And now we know that about 50% of people with osteoarthritis have damage inside the bone. On MRI, that's called a bone marrow lesion. But that's where people's pain is coming from, all these different things. And if you just forward next slide, the thing that's most important is probably tendons and emphases, where tendons are attaching to bone. Now, people just don't have an understanding of this. Most of my patients don't understand. They understand muscle because they can see that, but they don't understand the muscle is anchored at each end by a cord called a tendon. And inflammation there and in where tendons attach to bone is probably the cause of a lot of pain. And it's why people with normal x-rays have a lot of pain and say, there's something wrong with the test, doctor. And they're absolutely right. There is something wrong with the test. The test is not sensitive for picking up these things. I do a lot of imaging research. I do very little imaging in my clinical practice because people's stories tell me what's going on, and I don't really need to do lots of investigation. So the key thing about tendinitis is it's all reversible, and it's reversible by getting people strong. Next slide, please. So it's no news to many people that how weak you are makes you get more joint pain. I've got to tell you that everybody I see in clinic, just about everybody, cannot undo a jar, is very weak. When I meet people, I ask them to squeeze my hand, and it's rare for somebody to hurt me. And I'm not a muscly bricklayer, I'm a soft desk working rheumatologist. But most of the patients I meet are just incredibly weak. And grip strength alone predicts mortality, predicts outcome from so many different things. And it's a sign, it's a good measure of our generalized muscle fitness. And this is just one of many studies showing that the weaker you are, the more you will have pain. And this was just one study of knee pain. So what do we know? We need to get people stronger. Next slide, please. So I just want to spend a minute or two on this topic, and this is something I hope we would come back to in discussion. And what can pharmacists and the pharmacy team, pharmacist assistants, the whole bundle of people who work in pharmacies, I understand. Well, what can they do? I think, firstly, they can help with diagnosis. Now, if somebody has prolonged morning stiffness, and I can't reinforce that enough, but that's the trigger to get them seen by a clinician, get them seen by their GP or whoever's the right person in the system. By the way, if somebody says to you, my joints are stiff all day, doc, then that means there is no morning stiffness. Morning stiffness is something that happens in the first few hours of the day that changes over the rest of the day. And you can have 3 hours of morning stiffness, you can have 4 hours of morning stiffness, but if it's all day, then there is no morning stiffness. You've likely got mechanical joint pain. Pain worse with use, and at the end of the day, so most people who are on their feet all day, pharmacists working in shops on their feet all day, may have back pain and lower back pain or some knee pain after all time, and that's very likely to be tendon-related pain or osteoarthritis. So that's typical mechanical joint pain. It's worse with use, worse at the end of the day. I think somebody asked a question earlier about running and things like that. So things that get worse with use are what we would call mechanical problems. They're not inflammatory arthritis. And why is this so important, by the way, this mechanical inflammatory divide? It's because our treatments are so very, very different from mechanical and inflammatory joint pain. For inflammatory joint pain, you're going down a drug route. For inflammatory arthritis, rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, you're going to get NSAIDs, you're going to get methotrexate, hydroxychloroquine, leflunomide, and then you're going to move into biologic therapies, anti-TNFs, anti-IL-6s, and more recently, JAK inhibitors. So you go down a drug course for life. For mechanical joint problems, Laura's already touched upon the few therapies we have. We have very few effective therapies for these people. And we'll come to that, what there is. I'll come to that in a minute. But let's talk about this slide here. What else could you do? You've noticed I've said here this question about undoing a jar easily. If somebody's got hand pain, hand stiffness, can't get their rings on anymore, can't get them off, my hands are swollen, doc, generally they'll be very weak. We need to give them a simple exercise, and I can talk about that, but I'll come to in a minute how we can deal with some of these things. But generally, a grip strength exercise will get that person 50 to 60% improved with no drugs. Can you get out of a deep chair, a car, or in the UK where they love baths, people, I can say to patients, just watching them get out of the chair in the waiting room and walk towards me, I know that they haven't been able to have a bath in years because they're too weak. If you can't get out of a chair easily, you've got very weak quads. If you're getting pain in your knees on stairs, you've got weak quads. That's the large muscle of the thigh. And if people have had gout once, then it's generally always gout. Their joint pain is generally because gout is so terribly managed both by doctors and by patients. So be wary of and it's mostly males still with gout, although female numbers are creeping up. Beware of somebody who's had gout once before. And people forget, oh yeah, I did have gout 10 years ago, doc. Any new acute joint pain is very often gout. So if you've got somebody with prolonged morning stiffness, then that's a signal that they might need to see a specialist. Next slide, please. I mentioned Laura's talked about treatment of pain. Our treatment of osteoarthritis is indeed a treatment of pain because we have no structure modifying drugs and there are no licensed structure modifying drugs. And all guidelines, this is just the UK NICE guidelines, National Institute for Clinical Excellence guidelines, but all the guidelines from Osteoarthritis Research International, AUSI, or the American College and European League, all these guidelines say the same thing, that the core of any treatment is inflammation, muscle strengthening, and weight loss if you're overweight. Now, inflammation, I can't underestimate, is really important. Many people believe they're going to end in a wheelchair. Many people think a joint replacement is inevitable. Wrong. Most people will never need a joint replacement. And if they stay strong, they may never need much drugs. I haven't gone here because Laura was going to talk first and because this is your bread and butter. I wasn't going to talk to you about drugs, but you'll know we have very few options for common musculoskeletal pain. It's arguable whether paracetamol works. Topical NSAIDs help, but I think people apply it to the wrong part of joints and probably underutilized because it's a nuisance to do it multiple times a day. Opioids, well, Laura's gone into the problems of them, but they may have some short-term benefit. They look like they don't have much long-term benefit. And about 70 to 80% of people shouldn't be on NSAIDs, oral NSAIDs, and can't tolerate them anyhow. So most of our patients' drugs are not a big help, unfortunately. And that's why there's such a plethora of 5 million other products that might help you, but don't have any evidence base. Next slide, please. So I'm going to come back to this team. It said for the pharmacy team, you may be able to pick up some underdiagnosed inflammatory arthritis. And secondly, you can help point people in the right direction. I've mentioned we have very few treatments for common musculoskeletal pain. So information is really important. being able to to signpost people to appropriate websites for muscle strengthening, to help with weight loss. We know websites are probably for weight loss. We need something much more effective, and mostly weight loss requires some sort of intervention package. But for muscle strengthening, we're just starting to develop various pathways that will give you a course of essentially online physiotherapy intervention. And that's really important. Why I've been cautious about putting too much on this slide is the international nature of this meeting. And even within one country, within my country, there's no one exercise page I can send you to. I tend to use in the UK, our main arthritis charity Versus Arthritis has a good website. So that's where I tend to send people. But if you've ever Googled osteoarthritis and found the 10 million hits that you get, and tendonitis doesn't even mention, even though it's the cause of a lot of people's pain. We must develop lists, and this is one of my dreams in life, is that we develop local cards that give you a safe website you can go to. Because if you go online and look in most websites, what you will be told is complete nonsense, and most of it ends up with you spending money on something that will not help your joint pain. So we need to be able to hand out sheets to people saying, here's some trusted websites you can go to about your joint pain. Here's some trusted websites that will tell you about medications. And here's some trusted websites that will tell you how to do some simple exercises. And just off the top of my head, the safest thing that I get people to do a lot is walking laps in a swimming pool, because it has virtually no side effects unless you trip over and can't get out of the water. And most of my discussions in clinics is not actually about drugs, because by the time I see people, they've already tried paracetamol, NSAID, weak opioid have already been tried. So mostly what we're talking about is other options. And clearly we've got some tricks for intra-articular steroids, things like that, that offer short-term benefits, but not long-term treatment options. So last slide. I'll finish there with saying, because I've spent so long seeing so many patients who we don't help very well, I know that muscle strengthening remains absolutely the one thing that will reduce people's pain considerably. But it takes 20 minutes a day to do something, and taking a pill is much quicker. Can pharmacists play a role in this? Absolutely. I've said role in diagnosis, role in treatment. You already manage the pharmacological side of things. Now we need to start getting signposting to the other things that will make a big difference to people. We don't have enough doctors, we don't have enough physiotherapists, and every health system around the world is overwhelmed. But people are getting older, they're getting more joint pain. And after COVID, where people haven't moved for a year, all our MSK health systems are overwhelmed with joint pain. And we're all in big trouble as service providers in this area. So Louis, I'll stop there, or I might keep going for all afternoon.
Thank you so much, Philip, for sharing your expertise and your knowledge and different perspective as a rheumatologist. Actually, there's a lot of food for thought, and there are a couple of questions who actually have been mentioned on the Q&A. I kindly ask you just to go through them, please. So you can, some of them are very specific. So I kindly ask you just to go there. And then I remind every one of you that you can put your questions on the Q&A area. There's been some as well on the chat. So that's not actually the right place. Please just rewrite them on the Q&A so our panelists can go through them and answer if that's possible. And then if you want as well, at the end, we will have a wrap up, and prior to that, a panel discussion. And now it's time to move forward with our third and last panelist, Hilary McKee. She's a consultant pharmacist from Northern Health and Social Care Trust. She's a graduate from Queen's University Belfast. Hilary has worked in hospital pharmacy for many years, including time in psychiatry and in the private sector. She's now a consultant pharmacist, working in the fields of rheumatology and care of all the elderly. She has worked in rheumatology for over 20 years and has been pivotal in the development of pharmaceutical-led clinics. She won the 2008 have the innovations in rheumatology award for this. As an independent prescriber, she now runs 4 rheumatology review clinics per week, specializing in patients with inflammatory arthritis. In addition, she also runs her own Good Clinic. She's involved in teaching undergraduate and postgraduate students and regularly presents at national and international meetings. She sits on the Regional Biologicals Committee. She was a member of the NICE committee responsible for updating the rheumatology arthritis guideline. Hilary, thank you so much for your time. The floor is yours. Thank you.
Well, good morning, everybody, and thank you very much to FIP for asking me to speak today and for that lovely introduction. I think Lewis has already said quite a bit about me, but I am working currently in Northern Ireland, and it's interesting to see how widespread across the world that the audience is today. I'm a consultant pharmacist, and I'm also clinical lead of Rheumatology Pharmacists UK. I'm a member of the British Society of Rheumatology Education Committee, and I'm actually quite proud of that because it's the first time this year that a pharmacist ever had involvement in BSR. So I hope to progress with that and have more education available for pharmacists in the field of rheumatology. I'm an independent prescriber, and I'm not quite sure how widespread independent prescribing is throughout the world, but certainly in the UK, independent prescribers are able to independently prescribe all sorts of medications. So I can, without going back to the doctor, I can prescribe NSAIDs, I can prescribe DMARDs, I can even prescribe biologics or anything else in between that I feel confident and competent to do so. This is already said, I run 4 independent rheumatology review clinics per week. I've been doing this for a very long time. So I also, like Philip said, he's very old. I also feel very old in the field of rheumatology as well. Patients come to me with a diagnosis. So I don't try to make any diagnosis at all. I may have a good idea if a problem arises of what it is, but the doctors are the people who diagnose. And over here, the pharmacists in the hospital clinic are the ones who will deal with the medications. Next slide, please. So I've been asked to do a case study today, and we're going to go straight into this. Meet Mrs. Fisor. Mrs. Fisor is a 40-year-old female. She's type 2 diabetes. She's hypertension. She's only 5'3" tall. That's about 157 centimeters. She weighs 95 kilograms, so she's obviously quite overweight, and she smokes 15 cigarettes per day. Next slide, please. Current medication, she's on Rheumatoid, 5 milligrams a day. She's on metformin, 500 milligrams 3 times a day. She buys paracetamol on a very regular basis, and she's asking you to recommend something to help with the pain in her hands. She's been taking paracetamol 8 a day, and she's also been buying ibuprofen, and that is no longer helping. Next slide, please. So what are you going to do? This lady in front of you, I want you to think about what questions you're going to ask this patient. What examination, if any, would you undertake? And what signs would you look for? Next slide, please. The first thing I would ask is, have you pain anywhere else? Is it just your hands that are sore? Is the pain worse at any particular time of the day? Is it worse after exercise? Is it worse in the morning? Or is it worse in bed at night? And she responds, tells you she's worse first thing in the morning. You have her look at her hands to look for any tenderness, any swelling, any redness or heat. She also tells you that both knees are very sore. Next slide, please. That's a picture of her hands. If you look at your own hands, they may not look very much different to what you're looking at, but that is the classic early arthritis, early rheumatoid arthritis hand. Next slide, please. So you notice she's minimal swelling, but the second and third MCPs on both hands are slightly swollen. You start to suspect, does this patient have rheumatoid? The early morning stiffness is a good clue to that. And you ask her to go to her GP to get something stronger for the pain. So she comes back to you with a script for atoracoxib, 60 milligrams once a day. And as pharmacists being the expert in medications, you're going to look at every script, you're going to look at your patient, and very often we'll come up with potential concerns. So do you have any concerns about this lady's medications? Next slide, please. Sorry, I think there must be one missing there. What you're worried about in this lady is that she has hypertension. She's on atoracoxib, and atoracoxib may make her hypertension worse. 3 months later, she comes back to you. She's had a referral from her GP to an early arthritis clinic. Her shoulders, her knees, her wrists, and her MCPs, her fingers, are now affected. But she didn't like taking tablets. She doesn't like taking medications, so she stopped the atoracoxib. No particular reason. It did help a bit, but she didn't like taking it. Next slide, please. She comes back with a prescription for methotrexate, 10 milligrams once weekly, increasing to 15 milligrams once weekly if tolerated, naproxen, 500 milligrams twice daily, and omeprazole, 20 milligrams daily. And just have a think, is this appropriate? Next slide, please. You notice that folic acid has been omitted from the prescription. The usual dose is 5 milligrams once weekly, 24 to 48 hours after methotrexate. Her eGFR is down slightly, 54 mils per minute. So there are some concerns about the use of naproxen. She tells you that she had depomedron, 120 milligrams IM in hospital, which is very often given as a bridging therapy while we're waiting for one of the DMARDs to kick in. And you ask, is she taking, does she have adequate contraception? Methotrexate is very teratogenic. Next slide, please. She's on methotrexate for a little while and she returns to you again, and she's complaining of nausea and mouth ulcers. You're the community pharmacist. What are you going to tell her? Is the nausea a side effect of the methotrexate? Did she have mouth ulcers previous, or is that also a side effect of the methotrexate? How are you going to handle the side effects? Are you going to change the timing of the methotrexate? Sometimes we tell patients who are nauseous that if they take their methotrexate about tea time and take their folic acid 24 hours later, that may help. Are you going to switch to subcut methotrexate? Very often patients who have nausea and oral methotrexate can tolerate the injectable product much better. Or are you going to go into the realms of polypharmacy? Are you going to start adding an antiemetic to deal with the nausea? Are you going to add something else to deal with the mouth ulcers? As suddenly we're into prescribing cascade, more and more drugs added to deal with side effects? Or are you going to switch the drug? Next slide, please. What else can you do to help this patient? Lifestyle advice is extremely important. She's smoking 15 cigarettes today. It is well documented that patients who smoke tend to have worse disease and respond less well to medication. You try to offer her smoking cessation services, and she agrees to try that. She's very overweight. It's well known that for every 1 pound overweight that you are, there's an extra 3 to 5 pounds of pressure on the knees. She's in complaining with knee pain. It's a very sensitive topic. 40-year-old lady, are you going to say to her, you're overweight, you need to lose weight? And yes, you probably have to. And very often with my patients, I'll say, you do know that, we can't really do much if you don't take the weight off your knees. Sometimes I have people who are 125 kilograms coming in with sore knees asking to have knee injections. And it really is a no-brainer. What exercise does she take? Exercise is one of the best things that you can recommend to a patient. Philip mentioned swimming. Swimming is wonderful and it takes the weight off the affected joints. I've actually had a few patients who during COVID were unable to go swimming because the swimming pools were closed and their joints have subsequently flared. We talked about signposting to patient help organisations. For example, UK, Philip mentioned versus arthritis, or the National Rheumatoid Arthritis Society. In your own countries, you will have your own patient help groups. Next slide, please. So I just want to talk a little bit about what the community pharmacist can do for medicines optimization in practice. First thing you need to do is aim to understand what your patient is feeling. The patient has just had a diagnosis. It could be rheumatoid, it could be osteoarthritis, it could be gout, it could be any one of the 200 rheumatology conditions. This patient maybe knows very little about the disease. They've maybe had a relative who has had the disease and has ended up quite disabled. They're worried about disease progression. They're worried about, will they be able to continue to work? An awful lot of patients say to me, will I end up in a wheelchair? And say, no, we have good medications now. That's not likely to happen. They're worried about medicines. How many patients do you have coming in that are afraid to take medicines, or they take them for a little while and they stop them because of side effects, either real or otherwise? Next slide, please. Consider how your patient is feeling about the medicines and be prepared to answer their questions. The patient will come in and say to you, my neighbour is on drug X. Why can I not take that? They're doing brilliantly. I'm still sore. I'm sick on that drug. I can't take it. Can I change it? My neighbour told me to take drug Y. How many people are handling medications over the garden fence? How many are sharing medications, taking medications because their neighbour or their family member thought it would be useful? Or on the other extreme, my friend took that drug. It nearly killed her. I'm not taking it. I wouldn't take that, that's poison. And you will have an awful lot of patients coming in worried about their medication, and be prepared to talk them through possible side effects and their concerns. It's useful to tell them that side effect leaflets will list almost everything that has ever occurred, and that most patients will experience very few of those side effects. Next slide, please. Pharmacists ensure the safe use of medicines. Be prepared and be ready to manage adverse effects. Make sure doses are correct. Look for drug interactions. Look for clinically significant drug interactions. Sometimes pharmacy systems will flag up interactions that are theoretical and are not particularly clinically relevant. A number of occasions I have patients who have come back on, for example, methotrexate and NSAIDs. The NSAIDs have been stopped because it's been flagged as an interaction, whereas rarely, this is rarely clinically significant. What about temporarily stopping treatment? What about the patient who has had an infection or has had surgery and has to stop their disease-modifying drug? How are you going to manage them? The disease will probably flare. What about pregnancy? I mentioned the fact that methotrexate is teratogenic. Many of the disease-modifying drugs are teratogenic, and we do need to consider that. What about other comorbidities? This patient has hypertension. This patient has diabetes. Some of the drugs that we will use to treat these other conditions can interact or can have problems with the rheumatoid medications. Next slide, please. Make medicine optimization part of your routine practice. Those 4 principles that I've outlined should be key to how you're dealing with patients and their medications. Pharmacists are the most approachable, most available healthcare professionals that are around, and you will get many, many questions. Make sure that you're familiar with the drugs and that you're able to help your patients. Next slide, please. What about herbal medications? Patients often assume that herbal is natural and therefore it is safe. Patients will go out to the health food shops, to the herbalists, and they will buy all sorts of concoctions and not necessarily tell you that they're taking them. It's not always the case that they're natural and safe. Our patients are quite fond of echinacea. Echinacea has an increased risk of liver problems. Cod liver oil. How many of you as children were given cod liver oil? Caution with antihypertensives and warfarin. And in the UK at the moment, turmeric is being promoted big style as an anti-inflammatory. But there is a potential for interaction with non-steroidals and with sulfasalazine. Next slide, please. What about the patient who comes in and the disease is flared? A flare is when the activity of the disease suddenly increases. Increased joint pain, joints can get swollen, joints can get very stiff. Patient will ring and say, I am so sore, I can't move. Sometimes we don't know what causes it. Sometimes the disease is not adequately controlled. Sometimes they have done too much. We all have the patients who feel great, go out, clean the house from top to bottom, and the next day they can't move, and then they start to flare. Weather has been cited as causing flares. I'm not quite sure where the evidence for that is. Certainly with osteoarthritis patients, some are sensitive to changes in barometric pressure rather than heat or to cold. Stress and infection can also cause disease flares. Next slide, please. Remember, if you have a patient who comes into you with a flare, that flares will normally resolve spontaneously. And we reckon that within a week, they will normally be resolved. If a flare is lasting 2 or 3 months, it's not a flare, it's a lose of control. Flares will normally respond to heat and cold. So that's ice packs and heat. Rest the joints, reduce stress if possible. Gentle exercise is good. And if the flares are frequent or persisting, seek specialist advice. Next slide, please. So what about Mrs. Sore? Mrs. Sore is now switched to methotrexate subcut 15 milligrams once weekly. She's now on folic acid 5 milligrams once weekly, 24 hours after her methotrexate. Her joints are good. She's good disease control. She's lost weight. She's actually lost 1.5 stone. And she stopped smoking. So she really took on board the lifestyle advice. Her joints are good, and she's now managing on simple analgesia. That's an example of how a very simple interventions can help with managing your patient's Mrs. Very Sore. Next slide, please. Thank you for listening.
Thank you so much for your presentation, Hilary. We're going through like I'm not saying the daily basis of a pharmacist, of community pharmacists, but you ring a bell in many issues that we face when you deal with patients at the community pharmacy. So thank you for sharing your expertise and your knowledge. As I mentioned previously, you can write down on the Q&A the questions that we would like to have clarified by our panelists. They have kindly just started answering them while we were going through the other presentations. And as a wrap up, just for you to remember shortly what happened during this webinar, at the beginning with Laura, we started to understand that or to realize that 50% of the population will experience some sort of musculoskeletal pain during their life. It's a big number, and definitely community pharmacy need to be there to answer to this health issue. And roughly 20% will experience chronic pain. Went through the self-management of the condition through pain education, psychological, physical, pharmacological, and spiritual approaches, and also give a big focus on pharmaceutical care and, of course, on medical selection. And there was a focus as well on use of opioids. And there's been a lot of questions put on the Q&A, which actually have already been answered by Laura, focusing on this. And then we moved to Phil, who actually shared his expertise and experience as a rheumatologist on the other side. I mean, the one who actually needs to make a diagnosis. And he helped us understand that there's a role of the pharmacist to refer to a GP or to a specialist doctor. He clarified as well how he makes a diagnosis, and of course it's rheumatologist's responsibility to make a proper diagnosis, but going through the symptoms and everything that community pharmacy need to pay attention to, we'll be able just to reference patients that come up to us daily and might have been suffering from a rheumatology's issue. And then at the end with Hilary, we went through some practical cases, a very practical approach from the pharmacist's point of view. Hilary has an extensive experience with the conditions, with pain conditions, and she went through a couple of examples, discussing some issues that might arise while we're dealing with patients, not only with medicines but also with herbal preparations, and remind us that we need to be aware of some psychological aspects of our patients. We need to focus on the safe use of the medicines and also to deal with the expectations of patients. In the meantime, our panelists, as I mentioned previously, have already answered some of the questions that have been put on the Q&A. We're running a little bit short on time because unfortunately the presentations were very comprehensive and I decided not to cut them off at the 20 minutes, so that was okay. But anyway, I'll just maybe put a question to each one of the panelists and then we'll just close the webinar if that's okay. So we have a question here from Lars Oxoderben, who is actually the president of the community pharmacy section of FIP. He's mentioning here on the opioids, focusing on the opioid crisis in Canada. So this question will go for Laura. Is health information technology used to support responsible prescribing and stewardship? If yes, how? Follow-ups on prescribing patterns? And then if there is a collaborative approach with pharmacists applied? If yes, how? Laura?
Thank you so much. That's a great question. So in Canada, we are divided by 10 provinces and 3 territories, and our health information technology is different across different provinces. Unfortunately, we don't have a unified electronic medical record, and different provinces have variable levels. For example, in British Columbia, where the prescribing record is available to both prescribers and pharmacists, and it's complete in terms of its history, it is used extensively to support responsible prescribing and stewardship. In other provinces, like where I live in Ontario, it is limited. So we have information about some monitored medications, but only pharmacists can actually see this information and can choose to override it as well. So there needs to be a lot of communication increased over time. We see a real role for this to be able to support stewardship and prescribing in some provinces, but others are leading the way. In terms of this collaborative approach, I'll just be very quick. You know, I think that right now during COVID, there have been regulatory changes to enable pharmacists to both extend prescriptions in some provinces to prescribe independently to support patients with their access to medications and opioids specifically. And so, you know, that we've seen some improvement in terms of our scope of practice and continuity of care. But the outcome of all the activities, I don't think I have time to address that today. I think that, you know, we are seeing improvements related to appropriate prescribing, but we still have a lot of work to do.
Okay, thank you so much for that. Well, we'll take much more time just to go through everything that we want to share during the webinar. The intention here is actually just to give an overview, and then if people would like get to more, they can approach FIP or even do their research. And then I'll move to Phil. And as you mentioned, Phil, you are a researcher but a rheumatologist, so you are practice physician. During your experience, did you interact often with pharmacists during not only post-prescribing, just to follow up on patient? I'm aware that we have a lot of community pharmacists attending this session, so it's interesting to know what's your perspective of community pharmacy from your side, from the practical point of view, because you mentioned, of course, there's a role that you can play, which is okay, but from your own experience, what has been the interaction with community pharmacists?
Inadequate would be my answer, Louis, I guess. We have good interaction with our secondary care pharmacists in our institution, and that's been great. But I think we're missing a real trick. Most of the musculoskeletal pain is managed out there in primary care and out in the world. Mm-hmm. And pharmacists are really at the front line. And I wrote an editorial on this. I think you are frontline staff in the battle for what can be done. So we do need some better collaborations. We probably, I say this wearing an academic hat, we're going to need a grant or two to show the benefit of such interactions to change pathways, because I think there's some fear. I don't think the fear is on the patient side. I think there's some fear on doctor side, and I don't understand that, because most, when you talk to them, have had individual good experiences with their pharmacist. So I think we should be looking very much to use the pharmacy workforce as frontline for MSK pain. Mind you, the diabetes doctors probably want to use you frontline for the diabetes problems and everything else. But the big comorbidities that the world is facing for the next 30 years are going to be MSK pain, diabetes, hypertension. That's the comorbidities that will largely weigh down our systems.
Okay, thank you so much. And I think it's very common worldwide that this need is identified, but you still need to develop an enabler that can actually put all the stakeholders working together. And then I moved to Hillary, and from her experience, what has been your experience dealing with prescribers? What can be improved from your perspective? It has something to do with technology. Does it have to do with cultural issues? Do you think that it has to do more with something more limited in space, meaning that you have a circle of prescribers working in your area and maybe it's easy to make the communication, or is something to be done nationwide or regional wide to ease the process of making this enabler between prescribers and community pharmacists?
Okay, so do you mean, Louis, that what do we do about pharmacist prescribers or about prescribing generally?
Generally, I mean generally.
Okay, I think that pharmacists we don't like pharmacists to be the who say no. We want to be the pharmacists who say yes, go ahead, that is fine. And very often pharmacists, I think, by prescribers are perceived as being the people who will put their hand up and say, no, you cannot prescribe. You can't prescribe this, it doesn't work. So I think a better understanding of, for example, clinically significant, I did mention clinically significant drug interactions, not just theoretical drug interactions, so that the prescribers are not always being questioned by, is that what you meant? Did you really want to have that?
Yeah.
That will go a long way. Education about specialist drugs and about what can go with what. And always remember, guidelines are guidelines. Patients are not black and white. Patients are gray. So sometimes if you go and if prescribers tend to go outside the guidelines slightly, pharmacists are always very black and white, and pharmacists will have to realize that within prescribing, there is always a gray area.
Okay. Patients are gray. That's a good hashtag at the end of this presentation. Thank you so much for your panelists. And you are actually sharp on time. So again, thank you so much for your time to share your expertise and to prepare the presentation. The wrap-up has already been done. So on our next slide, you'll see that we have another event. So we motivate everyone who is attending just to register as well if that's of your interest. And then at the last slide, you can see also the connection to the events area of the FIP.org website. There's been some questions about how you can become a member. You just go to the website, and then just remember you all on September 25th, you have the World Pharmacist Day, and then you have also a campaign developed by FIP just to promote this event using an image who has already been prepared. You can also download it on the FIP.org site. We're still, long way to go to the Pharmacist Day, but the sooner the better. So this will be my last few words. Again, thank you so much for the participants, for our panelists, and I'm looking forward to see you in another event. Thank you so much.
Thank you.